se vuoi presentare.
Certo, quindi a me spetta l'onore di introdurre Claire Wilson, che terrà la lettura magistrale su salute mentale nel percorso nascita. Claire Wilson è una ricercatrice del Maudsley di Londra, ma è scozzese di origine, quindi ha studiato all'Università di Glasgow, dove ha anche ottenuto un primo diploma in Psychological Medicine, che forse noi potremmo tradurre come psicologia medica, anche se è un po' più spostata verso la psichiatria rispetto a quello che noi chiamiamo psicologia medica, tant'è vero che poi dopo, spostatasi a Londra, ha poi completato anche il suo training in psichiatria, quindi ha una specializzazione in psichiatria ed è anche membro del Royal College of Psychiatrists, quindi ha avuto la qualifica piena come medico psichiatra, nonostante la giovane età, un curriculum che sembra quello di una persona di 60 anni, ecco, quindi sia come clinico che come ricercatore. In particolar modo come ricercatore, adesso sotto la supervisione della professoressa Louise Howard, ha concentrato la propria attività sulla salute della madre e del bambino, con particolare riferimento al diabete gestazionale, su cui ha condotto le ricerche probabilmente più importanti e più citate a livello internazionale. Appunto il suo lavoro di ricerca avviene all'interno del Medical Research Council, che quindi ha un rilievo nazionale, ed è anche consulente per diciamo, l'equivalente del nostro Istituto Superiore di Sanità, quindi ha diciamo, tutte le carte in regola per poterci introdurre al sistema inglese relativamente al disagio perinatale. Credo di doverla tirare un altro po' più in lungo perché vedo che c'è qualche... Ce l'abbiamo fatta? Is it okay? Ready?
Okay, thank you.
Ok, allora niente, potete, per chi ha bisogno, mettere le cuffie e... Allora, in realtà come lettura magistrale normalmente non si prendono domande dal pubblico, però Claire ha detto che un paio di domande le riceverebbe volentieri, quindi limiterà la sua relazione a 30-35 minuti. Se qualcuno vuole prepararsi per un paio di domande saremo lieti di ricevere. Claire, I told them that a couple of questions after your presentation will be allowed.
That would be good.
So if you stay within 30-35 minutes, I'll show you when 5 minutes are
Thank you.
left.
Great.
Okay?
Thank you.
Prego.
Thank you for your kind introduction. And thank you also for having me here today. It really is an honour to be here and to hear about all the exciting projects that are going on across the country. So I bring to you a perspective, and it's important to acknowledge that because there are, even within the UK, geographical variations in terms of service provision. So I bring you a personal perspective, but also hopefully some of the evidence base on what actually works. Okay. Thank you. Great. Okay. So we're coming from a perspective of a National Health Service in the UK, the NHS. That provides free care at the point of access to everyone in the UK. And there is a body that I will regularly refer to within this presentation called the National Institute for Health and Care Excellence, which is called NICE for short. And they're involved in looking at the evidence on cost effectiveness and general efficacy of a range of treatments and setting guidelines according to that synthesis of evidence. And they have produced some guidelines that have provided you with a link to there on the provision of perinatal mental health care in the UK. It was last updated in August last year, and so much of what I will talk about is standards that have been set by NICE. Information on some of these slides. I'm not going to talk to all of it, but my understanding is that you will have the slides available afterwards. So that the idea is that you read some of this in your own time. Sorry. So, as I've said, NICE make these recommendations on perinatal mental health care in the UK. It covers a range of disorders, and they set a number of quality standards. So that's stuff that we should be aiming to do in providing perinatal mental health care. So I'm going to quickly go through them. First one is fairly specialised, so I'm not going to talk too much about this, but it is an issue that is flagged as extremely important, and it's around the use of valproate, which is used by psychiatrists for bipolar disorder or sometimes by neurologists for epilepsy. And it's just really important. As I say, it's fairly specific as a recommendation, but it has been highlighted particularly recently by the European Medicines Agency as being an issue. It's a highly teratogenic medication, so it's just really important for any women of childbearing potential who are taking valproate to identify this as a problem, because it shouldn't be happening at all anymore, only really in exceptional circumstances, and there's now a special programme that women should be enrolled in if they are taking this medication. So again, it's just really highlighting the importance of knowing patients, knowing what kind of medicines they're taking, and also are they likely to become pregnant. So thinking about even before women become pregnant, we heard this morning that there are a lot of women who become pregnant and who have a mental disorder, and we don't even know about it. Actually, even before women who have a known mental disorder become pregnant, what NICE have said is that there should be some counselling available in terms of options for medication when they become pregnant, extra support that they may need. And certainly within the service that I work in, there are sometimes women referred to our service who have a known mental disorder, and perhaps the GP is looking for some advice about their options during pregnancy. Keep forgetting. Pregnant. And so these are women with already known mental health problems, and often there needs to be a bit of a discussion around what's going to happen when I get pregnant, what support might I need in the postpartum, and a bit of a discussion around risks versus benefits of medication, and indeed other options that might be available that are not medication. And I'll come on to talking about that shortly. So there needs to be a bit of a discussion about the fact that some medication may be harmful. To be taking medication at all. For some women, there may be a good rationale for them remaining on medication. But for others, they may wish to come off medication. So it's a discussion with mum, with the wider family, and really considering that. And there's never a right answer. In psychiatry, I think there's often not a right answer, but even more in perinatal psychiatry, it's about acknowledging uncertainty. And actually, there's an awful lot of uncertainty in terms of a lot of these psychotropic medications in pregnancy. There's no randomized controlled trials. There's lots of case studies. So there's a lot of association, which may not be a cause and effect. All pregnancies have risks, and it's important to acknowledge that, regardless of whether or not you're on medication. And it's also important to acknowledge that a lot of these effects from medication that are seen, a lot of these risks are actually quite small. So I'm not going to talk that much more about medication because it's fairly niche and there's a lot of unknowns and there's not time to talk about specifics. But there is a little bit more guidance in the NICE guidelines. Just this idea that there is this changing risk-benefit ratio. So the general principles, given that there are so many unknowns with regards to medication, is that actually, particularly in what we say common mental disorders, so anxiety and depression, that actually there's a lot of benefit to initially going for psychological therapy versus medication. But again, that needs to be a discussion with the mum, weighing individual risks and benefits. But there is this stepped care approach, i.e. this idea that you start off with a psychological intervention and then gradually you may have to increase the intensity of what is provided. So, coming back to asking about mental health and well-being, I'm not going to talk loads about this because I feel like we spent most of this morning talking about this, but you'll see that what NICE recommends are the Hooley questions. They say consider asking, so they don't make a specific recommendation around this, which is a very deliberate political move, but consider asking the Hooley questions for depression, and another 2 questions about anxiety that are from a screening tool called the GAD-2. But again, as we acknowledged this morning, these are screening tools. They're not diagnostic tools, and there's no substitute for a good, thorough interview. And that can be done by not just psychiatrists, but midwives, gynecologists, all professionals who see women during pregnancy and in the postpartum. So I wanted at this point just to tell you a little bit about what services are actually available for women in the UK in the perinatal period, so both during pregnancy and in the postpartum, because there are some differences here. Important to stress that obstetric care in the UK is predominantly midwife-led. So there are a lot of women who do not see an obstetrician at any point. And there are highly specialised midwives working in very well integrated teams. Where I work, there are different teams that have different expertise. So there's the medically high-risk pregnancy midwives, there are the substance misuse midwives, and there are the midwives who help women with mental disorders. So there's a lot of midwifery care. And another thing that is quite unique to the UK is the health visitor. So the health visitor is usually from a midwifery or nursing background, and they work with families with preschool children. So preschool, so up to about the age of 5. And they don't work with all families, but all women in the postpartum will see a health visitor at least once. And so these are the kind of professionals who are often involved in the screening, in the asking, about mental health. And it is often the health visitor who will pick up on postpartum issues, because the midwives, will generally withdraw within about 1 month postpartum. So that's different as well. So if I see a lady with a mental disorder who I think needs a bit more input, I can ask for the midwife to see them up to 1 month postpartum. Most women only see a midwife up to 2 weeks, but we can request for some extra care. The other thing that I can request is for a health visitor to see the woman before she delivers, which again is not that common, but can be done, so that relationships are established early on. So in thinking about the kind of stuff that we should be asking in an assessment of a woman who we're perhaps concerned about a mental disorder, we should be thinking about all of those psychosocial stressors that can impact on outcomes. And there's loads. But one of the ones that I want to particularly highlight is domestic violence. And it was mentioned this morning. I can't remember who mentioned it. But it's such a big factor. Certainly in the UK, more than half of perinatal suicides in the UK, domestic violence is involved. So it's a massive factor. And also, as a psychiatrist, it disproportionately affects the psychiatric population, so the patients who I see, both in terms of perpetration and victimisation. And there's a lot of research on this area coming out of the department that I work in. So this is perhaps slightly self-indulgent, but there are some guidelines around this. And I'm not going to talk about any of this. I'm just going to let you read it in your own time. But that body who produced the guidelines have also produced guidelines on domestic violence. So, I mentioned that often, particularly for women with mild to moderate depression or anxiety, that psychological interventions have a lot of advantages. And so the current guidelines are that women receive, within 6 weeks of referral to a psychological therapy service, that they start receiving therapy. So quite ambitious. How do we go about delivering that? Because that's potentially quite a big demand on health services. Well, what is currently happening in England, I just want to briefly mention this, is this service called IAPT. So this is basically a way of the NHS delivering low-intensity psychological interventions at a mass, en masse. And so they employ these psychological well-being practitioners who are not psychologists, they're not clinical psychologists, but they've had some training on delivering low-intensity interventions, such as cognitive behavioural therapy, CBT. And patients can self-refer to IAPT, actually, so they can be referred by their GP, I can refer them, but they can actually refer themselves as well. So it is just a really good way of providing psychological therapy to a large proportion of the population. Whether or not it works is debatable, and whether or not it works for the perinatal population is currently being evaluated. And so I'm now introducing a package of research which is being conducted by the department that I work in. And it's looking at the evidence base for some of the interventions that are being delivered in the perinatal period. And the first of these research projects to the perinatal population. And so this is an RCT of a guided self-help intervention. References are there. This is the protocol. Results have yet to be published. But if you are interested in the intervention itself, you can obtain a copy of the workbook for the intervention by emailing that email address, and you can get a hold of it. Another research project coming out of this package of research is the Wendy project. So the aim of the Wendy project, and actually I wish I'd put in more of the results of this following this morning's discussion, but basically the aim of this project was to look at, are the Hooley questions any better than the Edinburgh Postnatal Depression Scale in the antepartum? So results of this have been published, references there. The bottom line is that they're probably equal. And actually, the Edinburgh Postnatal Depression Scale is 10 items. The Hooley question is 2 items. So I can't give specific recommendations, but they look comparable. And this was looking at their use for all mental disorders. And what I think is actually more interesting than how does the Hooley versus the EPDS perform is the fact that the prevalence lots of migrant women, that was mentioned this morning as well, was 27%. So it's a lot. And it was quite alarming. And it made for some nice media coverage of the paper. And it certainly made the headlines. But have a look at the paper if you're interested in the EPDS and the Hooley. Okay, so just moving on to the final quality statement, which is, I guess, perhaps more novel to this audience in that this doesn't really exist, whereas it does exist in the UK, is this idea of specialist perinatal mental health care provision. And so NICE are recommending that there be specialist services. Certainly within the UK, as I have alluded to, this is very geographically variable, and I work in London, and I think we're much better serviced than in many other parts of the UK. But they're recommending that these networks be established throughout the UK. And we've talked a lot about networks today, and that various professionals be involved in those networks. So what do we have available within the UK? So where I work in South London. The Maudsley Hospital is part of the trust that I work in. There are 4 areas. Each area has a community team specialised in perinatal mental health. And we also have a mother and baby unit as well. So I'm going to talk a little bit about both of those services. So the community perinatal team that I work in sees women from the preconception period, and we talked a little bit about that before, up to 1 year postpartum. We receive referrals from GPs, midwives, a range of health professionals, and we have a number of different members of those teams. So psychologists, psychiatrists, mental health nurses, and various others. I think I am going quite fast today. I feel like I need to slow down. How am I doing for time? Yeah, I'm going too fast. Anyway, so, yeah, I'm going too fast, clearly. So, in that team, how we tailor management to the patient is with the patient, we come up with a perinatal care plan. So the idea of that is that we have a plan right from the start when the woman is referred, which may be at any time in pregnancy or indeed in the postpartum. We have a clear idea of what we're going to be doing. And we also have various meetings, including one just before delivery, to come up with a plan for labour and the postpartum. And this is what the plan looks like. It's probably a bit small, but again, you can come back and read it later. There's various aspects to it, and it just kind of goes through the management at each point in the perinatal period. So I wanted to stop at this point just to think about, particularly given the audience here today, where our obstetrics and gynecology colleagues actually feature in the perinatal team in the community. And they feature at various points. So as I've mentioned, that pre-birth planning meeting, there are a range of different people there, including midwives, obstetricians, social workers, if they're involved. The other thing about the perinatal care plan is that it can be shared with a number of different agencies, with the women's consent, of course. But that includes obstetrics, midwives, GP. We also have a meeting once per week with different midwifery teams, and an obstetrician also comes to that. And that allows us to discuss the patients that we are seeing with the midwifery team. And that's interesting. Often you learn things that you might not have known about the patients, or they learn things as well. So it's a good way of just keeping abreast of everything that is happening. And from an inpatient point of view, there may be women on the labour ward, for example, who the midwives are concerned about. So maybe they've not seen the perinatal team at all during pregnancy, and maybe they've just delivered. Midwives are concerned, is this postpartum psychosis, or is the woman crying just too much? And so there is always a doctor in the team who will be called and asked to see them. And they can go and they can see women who are in hospital. Okay, so that's mentioned briefly today. So I'm going to tell you about our own mother and baby unit. It accepts referrals from across the UK. In reality, it's often women in and around London. There's 13 beds. This is a picture of the hospital that it's at. And it provides a range of different interventions, including a lot of psychological interventions, such as couples therapy, family therapy, and support around mother-infant bonding. But does this actually work? Is this any more effective than going into a general psychiatric ward? Nobody knows. It's a nice idea. There's one in the US, and there's a number in the UK. And I think there's also some in Scandinavia. But does it actually work? So this is me coming back to this program of research that we have, which is looking at outcomes, various outcomes, and comparing mother and baby units, a general psychiatric inpatient ward, and another thing that may also be fairly unique to the UK, which is these intensive teams that will treat patients at home and provide a bridge between admission and a kind of general psychiatric team in the community. So that's possibly quite unique to the UK. So it's comparing those three things. And I don't have any results yet. So we'll need to wait and see, but do follow us, do follow us. And there's a lot of interest now in the UK, actually, around, basically, this idea that it's about women in the UK who have less access to perinatal services than in other places. And particularly when the Duchess of Cambridge was pregnant, this was her interest. So the Prince Harry is all about adolescent mental health. Princess Kate is very interested in perinatal mental health at the moment. So this is great for us. So she came to the mother and baby unit, and this is her visiting. This is the sensory room that she's in there, and the video feedback room there. So the video feedback room is where there's this observation of mother-baby relationship. Yeah. And there's been various campaigns to highlight this unequal provision of services in the UK. So I guess it's really just highlighting, it's not all rosy, it's not all brilliant. There are huge discrepancies in terms of availability of services. So this is from 2015, so it's a bit old, but green is good, red is not so good in terms of number of services. Just a few other links to possibly some interesting resources. These are all bodies who have been campaigning for better provision of perinatal mental health services in the UK. So just some links there. And the really exciting news, so this is just England, Scotland's slightly different, but equally good. In England, there has been this huge investment recently in both mother and baby units and community perinatal teams, lots of money being put into developing services. And of course, with that comes a need for evaluation of services. So the Royal College of Psychiatrists in the UK provide a quality accreditation process, which again, I think is quite useful to maybe look at as you develop services here in Italy. And my hope is that here today and through continued sharing of ideas and research findings, that together we can continue to improve services for women and their children. Thank you.